I'm Dr. Tim Kosinski from Bingham Farms, Michigan, and today I want to compare two techniques for predictable, immediate implant placement following extraction. Now, I like to tell my patients when we have to remove a non-treatable tooth or non-restorable tooth, we will try to remove it atraumatically or minimally traumatically, meaning we want to maintain all four walls, especially the facial plata wall. And here today I want to demonstrate those techniques that I use to remove non-restorable teeth, but also how we can prepare the site for an immediate dental implant placement. Now there are several techniques to do this, and what I like to tell my patients is when we remove a tooth, we create a socket that is shaped like an egg. I think most of our patients understand that. Our implants can be placed into that socket site as long as we can get initial stability either through the lingual or palatal wall, or more importantly, through the apex. We need at least 2 millimeters of apical retention to maintain that implant. But we need to fill in the void between the implant body and the hard tissue or the bone itself. And to do that, we graft the site. And again, there are many different methods of grafting, and here I want to demonstrate two techniques that I use, or two different materials that I use to fill in the void or caulk the site, so to speak. So we're going to compare these two techniques, and here we have two different patients with teeth that need to be removed, and hopefully we can immediately place a dental implant and allow integration to begin. You can see the radiograph demonstrates significant decay in these teeth. So what I'll first do is take a high quality periotome and kind of go around the tooth structure to between the tooth root and the facial plate of bone to try to stretch that bone just a little bit. I'm then going to use one of my favorite instruments, the physics forceps. Now this instrument is rather unique in that it allows me to remove the teeth without really any force. There's no pressure put on the tooth as we would do with a conventional extraction. The instrument consists of two components: the beak, which is the shovel-shaped edge, which engages the lingual portion of the tooth 1 to 3 millimeters, and a bumper, which has a green silicone covering on it, that will be placed deep into the vestibule, or as deep into the vestibule as possible. The bumper is simply the center of rotation, is not the working end of the instrument. And what I will simply do is, without squeezing the handles, I will rotate my wrist here towards the shoulder to create tension on the lingual aspect of each of these roots. That tension will result in a physiologic release of enzyme, which will break down the periodontal ligament. Once the periodontal ligament is removed, theoretically the tooth will disengage up and out of the socket following the arc of rotation of this uniquely designed instrument. The instrument is not intended to remove the tooth in total, rather it's intended to luxate the tooth up and out of the socket to some degree, as you can see here. I will then take what we call a tooth delivery instrument, a forceps, and simply pull the tooth right out of the socket, maintaining that facial plate of bone miraculously. It's a technique that just takes a matter of moments. It is imperative that we prepare the socket site for our implant placement and our grafting. And so to do that, we want to curette. You want to remove any granulation and any purple blood, so to speak. We want nice red bleeding in that site. So we need a proper formation. Here the radiograph illustrates that the roots are removed in total. Here I'm going to go ahead and use my implant protocol. We start with a small pilot burr, a 2.2 diameter burr, and then widen the osteotomy to the size of implant that we want to place. Again, I'm using the apices of the adjacent roots as my guide in length, and I'm using the mesial distal position of the socket to determine my width of the implant that we're going to place. This happens to be a Han dental implant, and we will go through the surgical technique to create the osteotomy. Now, what I wanted to demonstrate was the different materials that we use in these techniques. And the material on your left, where we call it conventional grafting, I use a mineralized cortical cancellous allograft blend This is both cortical and cancellous or medullary bone. It is osteoconductive, and it creates an osteoconductive matrix for rapid site revascularization and structural integrity. And I can immediately thread an implant directly into that site, and go ahead and allow that implant to integrate for another 4 months or so. These particles are 250 to 1,000 microns in diameter, and this is probably a half cc worth of material. The material on the right is a material from Implant called Osteogen, or an Osteogen plug, and there's a small and a large. And this is simply a bioactive calcium apatite material in a bovine Achilles tendon matrix. It mimics the organic and inorganic components of physiologic bone, and I've done a lot of histologic research on this material, and I think it is just a wonderful product. I do not need a membrane using this product, in that the bovine Achilles tendon matrix prevents invagination of epithelium. The epithelium would rather grow over the top of the material rather than into the material. The literature will tell you, too, that we don't need a membrane if the space between the implant and the natural bone is 2 millimeters or less. And we also use the grafting material, again, as a caulking material to allow some more initial stability, but also to allow proper integration of the implant itself. So here we're placing the material, and you can see we wetted the allograft material with sterile saline or sterile water, and I'm simply engaging the socket. And on the right-hand side, we're taking our small Osteogen plug and placing it into the socket. Now, both these materials we're placing firmly, but I'm not condensing it. It's not amalgam. I'm placing it firmly, or packing it firmly into the site. I now have a grafted site that I will place my dental implants. Here we are placing them to position. In an immediate extraction site, I like to place my implants 1 millimeter subcrestal. This allows for a normal physiologic shrinkage of bone in that site. So here we are simply torquing the implants into position, into the proper position, and you can see we were able to torque the implants on the left-hand side to 35 Newton centimeters, and the implant into the Osteogen plug site to 45 Newton centimeters. So this is significant. We're getting our initial stability, obviously, from the apical portion of the osteotomy preparation. So the implants are placed and verified radiographically, and when we're able to get at least 25 Newton centimeters of torque, I can place a healing abutment very predictably. This becomes a one-stage procedure, and what that means to the patient is we no longer need anesthetic in uncovering. The healing abutment is actually slightly above the level of the tissue. On the right-hand side, I decided to go ahead and put a cover screw because my defect was a little bit larger, and I wanted to eliminate any tongue pressure placed on a healing abutment from this particular patient. Immediate postoperative views show the healing abutment slightly above the tissue and a cover screw on the right-hand side that is buried underneath the gum tissue. And the final radiographic determination shows that we have nice positioning of the implant and a immediate implant positioning following extraction and grafting, which will integrate very well in a short amount of time. Thank you.